At this time, I'll call the March 14, 2022 Board of Health meeting to order. Appreciate everyone's attendance tonight, and for those who may be watching online, we appreciate you watching us online. So the next agenda on the item, on the agenda is the public comment period. And Brooke, I did not have any emails, and you didn't have anybody to sign up, so there's no public comments. So we'll close the public comment period and move on to the minutes for the January 10, 2022 meeting. Board members, you should have a copy of those in your packet. And at this time, do we have a motion to approve those minutes as approved or presented?
I move to approve the minutes as presented.
All right, have a motion. Do I hear a second?
Second.
Second from Hope. All in favor signify by stating aye.
Aye.
Opposed? All right, motion carries and minutes have been approved. And next on the agenda, we've got Amy Scotton with us, and she'll provide us our annual legal update report.
Okay, good evening.
Good evening.
I will try to make this not as dry as it usually is, but it's hard because it's just your legal powers and your legal responsibilities, and it's legal things can often be a little dry, but we'll do what we can. Okay, first of all, the local Board of Health has the responsibility to protect and promote public health, and accordingly, you have the statutory authority to adopt rules that are necessary for that purpose. That power, however, is not without restrictions. If an area is already regulated by the Commission of Public Health or the Environmental Management Commission, then the local Board of Health can adopt a more stringent rule, but you cannot adopt a less stringent rule. And you can only adopt a more stringent rule if you determine that one is needed to protect public health. Otherwise, the rules that are already in place are what will apply. Secondly, you cannot adopt a rule concerning the grading, operating, and permitting of food and lodging facilities. The rules that the state operates preempt you doing that. And thirdly, a board can only adopt rules concerning wastewater collection, treatment, and disposal systems which are not designed to discharge effluent to the land surface or surface waters. If they're designed to do that, then they're regulated elsewhere. So those are the three main statutory prohibitions on your rulemaking. Now, like I said, that's statutory guidance. There's also some case law on what you can and can't do with regards to creating rules. Case law tells us that a Board of Health acts within its rulemaking powers properly if it follows these 5 guidelines. And the first 4 make a whole lot of sense to pretty much anybody. They have to be relevant to public health because that is your mission. So you can't just create a rule regulating something that has nothing to do with public health because that's outside of your area. The rule has to be reasonable in relationship to the public health risk that you have assessed. So you don't go crazy with your rule. It should reasonably address what you're trying to accomplish. It can't be illegal. So your rule cannot violate any law or any constitutional provision. It cannot be discriminatory in any way. And then finally you get to number 5. And number 5 is the one that's always a little confusing, and not just for local boards of health. It can be confusing for attorneys as well. Basically, the rule cannot make distinctions based upon policy concerns that are traditionally reserved for legislative bodies. So you read that and you say, what does that mean? And the easiest way to understand what that means is to look at how this number 5 has, what are the rules that this number 5 has been used to strike down. That's the easiest way to understand what's meant by that. And it has been used to strike down rules that were made regarding activities on Sundays versus other days of the week, or distinctions between certain types of businesses when making smoking rules, which really you don't do that now, but like if you had made a rule saying you can't smoke in a restaurant, but you can smoke in a bar before the state law, you couldn't do that because that is a distinction traditionally reserved for legislative bodies. If the distinctions basically are made on things like enforceability or economics, that's best left to the legislature. And I hope that makes sense. If you decide to enact a rule and we think that's a problem, we'll look at that in more detail. Okay. Now, back to more stringent rules. I just want to say this again. I said it a minute ago, but this comes up in case law as well. Although you can adopt a local rule that is more stringent than something in state law or the rule adopted at the state level, when you do that, you need to be able to clearly state why that needs to be more stringent here. Otherwise, you run the risk of it getting shot down if it gets challenged in court, okay? And this next thing I'm going to say doesn't get its own slide, but when you adopt a rule, you can adopt codes, standards, regulations, rules of other entities by reference. Specifically those of any agency of this state, another state, an agency of the U.S., a recognized association, and this board has done that. For those of you that have been on, if those of you that have been on the board for a while may remember that several years ago, the National Association of Public Health Veterinarians issued new guidance on rabies and rabies control measures, and this board adopted those by reference and incorporated them into a new rule. Now, later, when the state changed its rules and regulations, when the state said, okay, we're going to change the law to follow those guidelines, you rescinded your rule because it was no longer needed. And that's what you're going to be doing later tonight with regard to some outdated smoking rules that we have. Okay, so how do you enact a local Board of Health rule? Okay, first, at least 10 days before the adoption, amendment, or repeal of any local Board of Health rule, the proposed rule has to be made available in the office of the county clerk, which is the clerk to the Board of Commissioners, and a notice must be published in the newspaper, and the notice has to contain the substance of the proposed rule and a description of the subjects and issues involved, the proposed effective date of the rule or the effective date of the repeal, and a statement that copies of the rule are available at the local health department, which really sounds odd, but that is what the statute says. Did anybody catch that you have to make it available in the office of the clerk to the board, but you have to publish that it's available at the health department? Yeah, go figure. I think we usually say that it's available in both places. But the rule becomes effective when adopted unless a different date is specified within the rule itself. So, where are public health rules applicable? Rules adopted by a local Board of Health apply countywide, even within the municipalities. And this is one way in which a Board of Health rule differs from an ordinance adopted by the county commissioners. Ordinances are effective in the unincorporated areas of the county unless a city takes certain actions to allow those to be effective within the city limits. A Board of Health rule applies countywide, and copies of all rules have to be on file with the secretary for the Board of Health. Now, I know the smoking rules, the newer smoking laws are a little different in that you adopt a rule and then the Board of Commissioners has to adopt your rule to make it effective countywide, but that's really the only area where that's the case. Okay. So if someone violates a rule under 130A-18, the local health director can institute an action for injunctive relief or pursue it criminally, Violation of Board of Health rules is a misdemeanor. Now, you also have, in addition to rulemaking responsibilities, you also have some appeal responsibilities. You have the responsibility for hearing and adjudicating appeals, and those are appeals of rules that are adopted by the Board of Health and of administrative penalties imposed by the health director. So the health director has the authority in some instances to impose penalties. For example, administrative penalties can be imposed upon someone who willfully violates wastewater collection, treatment, and disposal rules, or who willingly or willfully violates a condition imposed on a permit issued under approved local rules. In imposing an administrative penalty, the health director has to take a number of things into account. The type of violation, the type of waste involved, the duration of the violation, the cause, the potential effect on public health and the environment, the effectiveness of any responsive measures that the violator took, the damage to private property, the degree and extent of harm caused by the violation, the cost of rectifying any damage, the amount of money the violator saved by not complying, and the violator's previous record of compliance or non-compliance. So whenever, if Tara were to be considering an administrative penalty, she had to consider all of those things in determining whether or not to institute one. Note that I gave you an example of something she can impose an administrative penalty for. She can't do it for everything. Only those things that it specifically says she has the power to give administrative penalties for. But if she imposed one and somebody wanted to appeal that, they could appeal that to you as a board, okay? People can also appeal rules that you have adopted. So if they don't agree with the rule that you've adopted, they can appeal that also to you. And the procedure for both of these types of appeals is exactly the same. So here's the procedure. We're going to talk through that really quickly because it's important that you as a board understand the time frames that we're talking about here because they're very, very tight. Basically, if a person wishes to appeal, that person must send written notice of the appeal to the health director within 30 days of the challenged action. Okay, the notice of appeal should include the name and address of the aggrieved person, a description of the challenged action, and a statement of why they believe that action was incorrect. Within 5 days of that notice, of receipt of that notice, the local health director has to send the notice of appeal to you, okay? Within 15 days of you receiving that notice, you have to hold a hearing on that matter. And the appellant has to get 10 days notice of the hearing. So you really have to have set your hearing within 5 days to be able to meet your notice requirement to the appellant. So you see, it's a really quick turnaround time on getting your hearing scheduled. At the hearing, the board will hear information from the appellant and other witnesses, and then you as a board will either affirm, modify, or reverse the challenged action and issue a written decision. The written decision has to contain a concise statement of the reasons for the decision and inform the appellant of their right to appeal your decision, which they can appeal to district court within 30 days of you issuing it. Did you have a question, Mr. Ferguson? I saw you looking at me like you might want to say something, so.
I didn't remember. Is it district or superior?
It's district. Yes, sir.
And these are calendar days?
Yes.
Right, Amy? Okay. So once a appeal is received by Tara, we really have 10 days, her 5 and our 5, to have a hearing, correct?
Well, no, okay. She has 5 days to send it to you,
Right.
and then you've got 5 days to set your hearing. You
set the
can't
hearing.
really have the hearing that fast because you've got to give the appellant 10 days for the 10 days notice of the hearing.
That's right, okay.
But you have to hold the hearing within 15 days of your receipt of notice of it from Tara. So it's really quick. It's really quick. Really, to be safe and not get tripped up, you would probably want to set your hearing maybe within 2 days after getting the notice from her. So that, because then we've got to get the notice out to the appellant. I don't know why they wrote it that way, to be that fast, because it's really hard on you as a board. I mean, you're a large board, and you're going to have at least a quorum to be able to hold the hearing. Yeah. It's tough, but that is state law. That is not a rule that we came up with, so. Okay. As a local board of health, you also may impose fees for services to be rendered by the health department, except where the imposition of a fee is prohibited by statute, or where the services are performed as an agent of the state. Fees are based on a plan recommended by the health director, and they would be approved by you as a board and also by the Board of County Commissioners. And fees that are collected pursuant to this are deposited into the local health department account, and they have to be expended for public health services. So they don't just go into the county general fund or anything like that. And then just remember that as a board, you have access to legal advice whenever you need it. My contact information is on this slide. I'm also on the county website. Tara's got my cell even, so I don't want to put that on the slide because I think you're broadcasting this to the world. But if you need me and I'm not in the office, Tara can help you reach me. And if you have any questions, I will try to answer them now.
Any questions from the board?
All right, thanks.
Thanks, Amy. All right, Tara, you're next with some outdated rules that we want to take a look at.
Before I get to that agenda item, I do want to say thank you to Amy for coming tonight. But also, I do have her cell phone number, and I actually talk to her probably more than she likes talking to me. But she's very helpful. She's very helpful. She's helps me think through, talk through. I don't know if I should have done that. Anyway, but thank you, Amy, for your help always. I also want to recognize a couple of public health team members that aren't always at our meetings. Elizabeth Aviles Gonzalez, she is a foreign language interpreter and clerk to our front desk, supervisor to our front desk clerks. She does a really good job at what she does. And then we have Addison Salisbury. Addison is one of 3 public health school liaisons. We received some COVID funding for temporary part-time public health school liaisons. And Addison and her teammates, they are available to help schools with anything they need assistance with COVID related, whether it's providing guidance, if anybody's interested in setting up a vaccine clinic, anything like that, they're available. So we're glad to have you here tonight, Addison. All right, so to the agenda item. In your packet, you have 2 Randolph County Board of Health rules. One that was adopted in 1993, and the other was adopted in 2008. The 1993 smoking control rules, this particular rule did 2 things. It prohibited smoking in publicly owned buildings, and it established rules concerning the designated smoking areas in restaurants. If you look at the rule in Section 1, Paragraph E, It states that any federal or state municipal law or regulation giving greater protection prevails over this rule. When the North Carolina General Assembly enacted 130A-496 prohibiting smoking in restaurants and bars entirely, that was back in 2010, that superseded this particular rule as to restaurants and bars. When the Randolph County Board of Commissioners enacted the 2019 ordinance, the Tobacco-Free Grounds Ordinance, it gave more protection in county buildings and on county property than this 1993 rule. So the rule was superseded by the ordinance in that regard. The 2008 Health Department tobacco use rule, this rule prohibited smoking in the health department and 50 linear feet away from any health department building. Section 1, paragraph E of this rule also provided that the provisions of any federal, state, or municipal law or regulation that affords greater protection would prevail over this rule. So again, the 2019 ordinance passed by the commissioners that prohibits tobacco use on county property entirely affords greater protection and therefore supersedes this rule. So that's why these rules are being brought before you tonight with the request to rescind them. Does anybody have questions?
All right, any comments or questions from the board? All right, we're going to take these one at a time, correct? Mm-hmm. Okay. Do I hear a motion to rescind the 1993 smoking control rules?
So moved.
Second.
Motion from Alan, second from Robert. Is there any discussion? All right, so all in favor signify by stating aye.
Aye.
Opposed? All right, the first one is approved. Now do I have a motion to rescind the 2008 tobacco use rules?
So moved.
Second.
Alan's a motion and a second from Robert. Any discussion? All in favor signify by stating aye.
Aye.
Opposed? All right, that one motion carries. Thank you. So Terry, you're next on the agenda with the child fatality report for 2020.
Okay, you have a copy of the report in your folder. In accordance with North Carolina General Statute 143-576 1A2, the Child Fatality Prevention Team annual report must be presented each year to the Board of County Commissioners and to the Board of Health. I presented this report to the commissioners back in February, so tonight we're going to review it here. Just for those who aren't as familiar, every North Carolina county has a child fatality prevention team, and that team is composed of members that are representative of public and non-public agencies in the county. Those agencies usually provide support or services to children and their families. There's on the back page of the report, you can see a list of the members that serve on the board, so you can see how diverse this group is. So the team meets to review child deaths, and when we meet, like right now, we are in calendar year 2022. So when we meet quarterly this year, we're looking back at child fatalities from last calendar year. So this report is from child deaths from 2020. These are the ones that we reviewed last calendar year. So we review the child deaths for children 0 to 18 that reside here in Randolph County. Doesn't matter where the death happened, if they reside here in Randolph County, we're going to review that death. And we are looking to identify any potential gaps in any of the services they might have received, so that we can look for ways, could that death have been prevented? And if so, what are we going to do about it? We met virtually 3 times in 2021. Unfortunately, we were notified in December that the fourth quarter deaths were going to be late, so we ended up looking at those in January. But all of those deaths from 2020 are part of this report. In calendar year 2020, there were 23 child deaths that we reviewed. And as you go through the report, you can see what those causes of death were. There were 3 children that died from an accident. An accident could include a motor vehicle accident. It could be choking, drowning, something like that. There were 2 children that died from birth defects. Those are usually congenital. Something's happened before the baby gets here. 5 children died from an illness. That could be a viral infection, cancer, things like that. And I mentioned at the commissioners' meeting, we have not had any children die from COVID, but if there had been, it would be under illnesses. 6 children died from a perinatal condition, and it could have been a clinical problem during pregnancy. Examples include, extreme prematurity. They were born with a cardiac condition or defect. And then other causes of death. There were 4. Yes, ma'am.
Would drug use by a mother, if it caused something, would it go under perinatal condition?
Possibly.
If it was determined
I would
that
think these causes of death come off of the Office of the Chief Medical Examiner. That's how they list the cause of death. So based on what I've seen, it probably would. There were 3 children that died. Hang on, sorry, I'm getting down, there were 4 children that died from other. And examples of other could be, it's listed as ill-defined and unspecified, so there was no clear explanation. But that could also include like unsafe sleep, because a lot of people do that more so than they should. And when I'm saying unsafe sleep, I'm sure you all know that's, a parent puts a child in bed with them or on the couch with them, and, the child falls between the bed and the wall or just suffocates where it is in the bed. So we continue to work with the Partnership for Children to get information about safe sleep practices out to, I think we take stuff into the hospital, or the partnership does, to the hospital to get information in the hands of moms with new babies about safe sleep. So based on the review of the child fatalities, there were no gaps identified. I skipped one, I'm sorry, because this is a big one. The very last one is suicide. We had 3 children, 0 to 18, that committed suicide in 2020, which is troubling. Again, I said there were no gaps identified, but with there being 3 suicides identified, the child fatality team is going to seek out some training on adolescent suicide prevention so that we can get information out to folks to hopefully prevent other families from going through suicide of a child. To stay well informed and up to date on current information, it's not uncommon for the child fatality team to have training, like some of our health education folks and our child health nurse provided some training for the child fatality team about unsafe sleep, car seat safety, those kinds of things. And then I've already mentioned that we continue to partner with the Partnership for Children. And I believe that concludes the child fatality report for calendar year 2020. Does anybody have questions?
Any questions for Tara on the report?
So are the suicides up 2020 in comparison to 2019?
Yes. I don't know that I have that number with me, but they are up. Not only among children, but adults as well. Yeah.
How about overall child deaths?
I think this was, in comparison to the previous year, I think we were down by 2 maybe. Mm-hmm.
Anybody else? All right, thank you, Tara.
Mm-hmm.
Jennifer, next on the agenda is Jennifer Layton, and she's going to go over a couple items for us, starting with the Board of Health manual. Hey, Jennifer.
Hey, good evening. I hope everyone can hear me okay, even streaming at home. I'm going to cover a few items with you, as Mr. Trotter mentioned. In your packet, Brooke so kindly put together, you notice in the left-hand side of your packet, you have a nice stack of paperwork there. So each Board of Health member receives a manual at the beginning of your term, and annually we review those materials for accuracy and we update accordingly. We also provide your new materials to replace outdated materials or to add to your manual. And so that's what you have in that left-hand side of your folder. And included in that packet right now is a new title page, a letter from Health Director Tara Aker, the Board of Health members list, which includes your board role, your contact information, and your terms. There's also the Health Director job description, an updated organizational chart, which feels like it changes a lot for us quite frequently. Board of Health operating procedures, which you all approved in January of this year, and our latest 2020 to 2022 strategic plan, and you'll receive an update on that plan next meeting. Any questions on the materials you've received?
I think so. Thank you, Jennifer and Brooke, for your work on this. All right, just go ahead and go with the
Accreditation?
something else. Yeah, the accreditation.
Okay, sure. I was waiting for you to prompt me as the chair, but I'll be happy to move on to accreditation. So some of you became new board members after our latest accreditation cycle. So just wanted to give you a little bit of background really briefly so you understand what we're talking about when we mention accreditation. The North Carolina General Statute 130A-34.4, which was effective July 1st in 2014, states local public health agencies must be accredited by the North Carolina Board in order to continue to receive state and federal funding. Very, very important, right? We have to have the funding to operate and provide services to the community. Accreditation is a three-step process. The first step is the health department self-assessment. That's where we spend the cycle gathering all of our evidence to prove that we're meeting all of the requirements. The second step is a site visit. So a designated team of folks from all across the state representing different industries. They might be local health department staff, things of that nature. They will actually come on site and visit our building. They'll do an assessment. They'll look at cleaning logs. They'll look at safety and security of your building. Are you ADA compliant? They're looking for things physically in your building, as well as reviewing personnel files that Brooke keeps records of, training logs, and things of that nature. That third step of the process is the adjudication, and that is the North Carolina Local Health Department Accreditation Board determines status based on the site visit team recommendations. So they will make a recommendation whether we are to be reaccredited or not. And they oftentimes will give you an opportunity to fix whatever errors they find, which is great. It gives you time to fix it, resubmit your evidence, and possibly get reaccredited. A typical accreditation cycle will span 4 years, and the last accreditation cycle that Randolph County Public Health had was in early of 2018 completion, where Tara led that team and they were accredited with honors. No pressure for the rest of us. But due to the pandemic, the North Carolina legislators voted twice to extend the accreditation cycle 1 year per vote they made. Which means our accreditation cycle now spans 6 years. So we have 6 years of documentation to collect, and the whole state is behind. So we're like little ducks on the water, paddling away trying to get caught up. Our next site visit should be held in early 2024. It could be January, February, or March. It depends on the site visit team's availability. And this year, they're actually piloting virtual site visits for the first time, which would be less stress on us. So cross our fingers it goes well. All supervisors and program coordinators have received documents, including responsibilities by activity. We assign them by what that documentation entails. Is it relevant to environmental health? Is it relevant to clinic? We assign those responsibilities to each supervisor or coordinator. And just as an FYI, you all are incredibly important for accreditation. We collect a lot of Board of Health meeting minutes and activities that you all do. So Tara providing you the Child Fatality annual report, that's an accreditation requirement. The legal training you received today, that's an accreditation requirement. So you all, we really appreciate you because you are critical in our accreditation to continue to serve the community. So we have a core team that leads the accreditation documentation collection that is comprised of Brooke Thomas, Wendy Kennan, and myself. And we dedicate 2 full days a month right now to get caught up. where all we do is review evidence that's submitted by our team. We reach out to supervisors about 2 weeks before and say, here is the documents that we would like for you to submit to us so we can review and make sure we have everything we need. And we will get together and we review those documents and determine, does it meet requirements or not? Is something missing? And do we have to reach back out and ask for something more? And as of April 13th, Tara and Susan were brilliant. They had contracted with a consultant in the previous accreditation cycle that helps ensure that we're meeting all those requirements for the state. And they typically would meet with her quarterly. We're going to attempt to meet with her a little more frequently to get caught up because it's going to sneak up on us pretty quickly. And she's coming in April to help get us caught up and take a look at what we've already collected. Any questions on accreditation?
Just a comment, when the accreditation team does come, members of the board are asked to meet with the accreditation team. I know the chair has to, and then I'm not certain how many volunteers. I did this last time, it was a great experience.
And it may change, because with it being virtual, they may not require interviews anymore. It really depends on the pilot and how it runs this year. But that's a great point.
I don't know if there's any comparison, but the county schools is currently going through accreditation. And so there was a meeting today of community partners, and it was virtual. So.
You can probably attest to that better than anybody, right?
Yes, that was a lengthy process, certainly. And I think because of COVID, theirs was delayed a couple years as well, so they're just getting into that process.
But it worked just fine. It was
Yeah.
Yes. Yes, a virtual visit doesn't require, pulling staff away from their duties to be hosts to a team for 2 or 3 days. And I know I haven't been part of that coordination, but I know it wasn't fun the last time you had to do it. It's a lot of planning that has. It is a lot of planning. So, okay, any other questions?
Any other comments or questions? All right, thanks, Jennifer.
I have one more item. You want me to go ahead and cover Opioid Collaborative?
That's fine. Yep.
They were combined, sorry. So as a quick update, prior to the pandemic, we had the Randolph County Opioid Drug Community Collaborative that was formed, and Susan was a big part of that, as well as some health educators. Tara was probably involved with that group. It was a big, big group. Around 80 representatives were part of that group. Of course, during COVID, a lot of the coalition, grassroots coalition work that health departments would do dwindled, and that's just because we had to shift our focus. What worked out great was they wrapped up their original opioid action plan in 2018 at the end of the year, so it was good timing for us. So we are trying to resume and reconvene that collaborative. We started back in September of 2021. We meet every other month, and in September we had a reintroduction of the collaborative. We discussed opportunities to build on the previous work that the group had done. They had some great successes. And in November, we reviewed the North Carolina Opioid Action Plan dashboard, and you all can see that. That is a public-facing dashboard. We determined our meeting format going forward, and the collaborative wanted to continue bi-monthly meetings with a featured speaker, so we're continuing that flow. And in January of this year, we started inviting those speakers back, and I don't know if you all are aware, but during COVID, Daymark opened a behavioral health urgent care, so we had Tyler Kazaya from Daymark present on that very vital resource. That is such a special resource and can really serve as a clearinghouse for a lot of behavioral health needs, including substance use disorder. What a treasure we have in this county. We also discussed North Carolina Opioid Settlement Fund's resources that are offered by the North Carolina Attorney General's Office, as well as evidence-based strategies. And we are trying to initiate 3 work groups. It's really hard when you just meet about an hour, hour and a half every other month to really see your work come to fruition. So we are trying to initiate 3 work groups to work in 3 areas the state wants us to focus our work. One is prevention, the second is harm reduction, and the third is connect to care. And it encompasses very specific evidence-based strategies. I am recruiting hard for work group chair for each of those teams. We have 1 committed for prevention. I need 1 for harm reduction and 1 for connect to care. The nice thing is people are coming back to, we are emerging from COVID. People are getting excited about community work again, and they're coming out of the woodwork. I have met people from Randolph County in webinars, and I'm like, are you aware of the collaborative? no, we'd like to have you join us. And they're really excited to hear about it and join our meeting. Our next meeting will occur in 2 weeks, March 28th at 2 p.m., and there's going to be a presentation on plan of safe care, and that links back to sort of what Tara was speaking about with child fatality. Plan of safe care is for children that have been potentially diagnosed with neonatal abstinence syndrome right after birth, or there's a concern that the parents are in current substance use, and they are connected to support and resources through DSS and the health department. So we'll have a presentation on that. And in addition to that, I just wanted to mention, we are planning to use a new framework to build our action plan going forward. It's a new framework the state is pushing us to utilize called results-based accountability. You may or may not have heard about it, but it is designed to flip your planning. You focus on what outcome you want, and you work backwards. We tend to focus on the problem and get hung up on it, and how do we fix it? So it's an interesting approach. But it will allow us to incorporate a lot of our strategies and data into a public-facing dashboard the state is providing us with. So, any questions?
Any question, board members? Okay, thank you, Jennifer.
Thank you, I appreciate
Thanks for
it.
your work on that collaborative. All right, Terry, you're back up.
The next document in your packet should be mid-year financial statements for this current fiscal year. So we're going to be looking at where we are from July of 2021 through December of 2021. So the first page is our expenditures. All of our programs are listed out there on the left-hand side of the page. Excuse me, that middle column, the middle two columns are what we budgeted. Our actual expenses are next, and then the percentage on the far right for year to date. Ideally, at the end of December, we should be close to 50%. So if you look at administration, at the end of December, we were at 31%. The reason we may not be close to 50% is, certain things like we order, we have computer replacement or electronic devices replacement. We usually do that January, February-ish. So the funds for that had not come out of administration at that point. Child Health Smart Start, we're pretty close. Care management for at-risk children, we're at 42%, so we're not quite to 50%, and that's probably due, we were down a position, so that's probably why we weren't near 50%. COVID-19 funds, you can see how much we had budgeted. That's the COVID money that we've had, $1,727,000. We've spent a lot of our COVID money over the past couple of years, but there's one pot of money that's particularly hard to spend. There's lots of strings attached to it, so we have to make sure we're spending it the way the state is asking us to spend it. It's CDC money. What I would like to use that money for is, and I'll get to that a little bit later on, but we need some renovations. We've learned a lot about COVID in our space and lack thereof. So I'll talk about that in a little bit, but we'll have to ask the state for permission to use the funds how we'd like to use them. Dental health, we're only 24% there, and that's probably largely due in part to we've got that grant, I can't remember, the Duke Endowment grant for the school-based oral health program. So a lot of those grant funds are sitting there because we have not yet started purchasing or implementing that program just yet. Environmental health, they're about where they should be. Health education, they've had a couple of positions, that public health strategist position, we posted that position for a year and never had any success at filling that position, so we're going to reevaluate what we're going to do with that position. And we've had a health educator position that we have not, I don't think we need that position at this point, so we'll look at how we're going to, what we're going to do with that position. WIC is about where they need to be. Family planning isn't in a bad place, but our numbers still are not back up to where we need to be as far as, the delay in getting services back up to full speed. So that's, I'm sure, partly to do with that. And then our care management, they're at the care management for high-risk pregnancies. I think they're at a pretty good place. So that's what that is. Does anybody have questions about our expenditures? If you'll flip to the next page, you're going to see our finance, our revenues, specifically our fees that we collect. Again, you'll see the program area, how much was budgeted, and how much we've received of those budgeted fees, and then where we are at the end of December. Most of our program areas are in a good place. You'll see in administration, we budgeted we anticipated collecting $9,500 in fees. And what that is prior to COVID, I don't know if y'all remember this, but we have an agreement with Mercy where one of our family nurse practitioners, she would go down there a few days and help them with some maternal health stuff. And so they would pay us for the time she was down there doing that service. But during COVID, we haven't reinitiated that service. So that's what that $9,500 is. And then the Smart Start fees that we anticipate making $9,000. Again, that's impacted by COVID. Our child health nurse consultant, she does a lot of the training and education for our local child care centers. She does CPR, first aid, those kinds of things. And with COVID being in place, we've not offered those. We are just now getting back to offering those in person. So that's what that is. And then everybody else looks like they're above and beyond the 50 percentile. Any questions about that? All right, the next page is our revenue specifically to Medicaid fees. So that's any billable services that we seek Medicaid reimbursement for. So again, we're looking for that 50% mark, and we are near or above in every area. You will notice that our Medicaid settlement, we budgeted $229,381. And so far, we've not received that yet, so it's going to exceed that because we will get back, once they withhold the 10%, we're going to be looking at a $543,000 cost settlement. Any questions about that? All right, the next page, that's just an explanation as a whole, what our revenues are. That combines everything. That's our contracts with the state, it's our local funds, it's any grants, any potential revenue source is factored on this page. I won't go line item by line item. I'll just take questions if anybody has questions about any of those as you look down the list.
Tara, I have one. When do you expect the Medicaid settlement to come in?
I don't know that we have an anticipated date. It's been submitted, you know, and Medicaid transformation has delayed things. It's kind of thrown a wrench into our get along. We expected that because any time you change something significantly, there's hitches in your get along. But we'd hope things would be smoothed out a little more now. But I'm not sure when we'll get that cost settlement. Anybody else?
Any other questions?
The last page is our amended expenditures. This probably should have just been included with, we'll look at the budget next month. This probably should have just been included in the budget. But this is from last year. You know, sometimes if we don't spend all of our funds, we'll carry it forward. And, you know, again, with COVID, we didn't purchase things like we did because we were so focused on COVID. And I won't, you guys can just look at this line item by line item. I'll point out, like environmental health, food, on-site wastewater. If you look down that $27,000, I know we've used that this year. Wayne's folks needed new Trimble devices related to their septic system work. I know we've replaced some of those. If we don't spend all of this, it will probably we'll request to carry it forward or go into budget reserve. Because again, we're good stewards of our money, but again, there's a space needs issue at the health department that I'll get into during the director's report. Anybody have questions about the carry over funds from 2021.
Any questions? All right, thanks, Tara.
Yep. All right. All right, so the health director's report. I'm gonna start off with COVID. Y'all, it's been 2 years. 2 years on March 4th. I think a lot of us at Public Health have PTSD a little bit, and I don't say that lightly, but we look back and think, wow, 2 years ago, we've lost, I won't say we've lost, but it's been 2 years. March 4th, 2020, we opened the Emergency Operations Center at the Health Department. April sent me a link to a video from when we did the town hall meeting here in this room right here. That was 2 years ago this past Saturday. I told her I couldn't watch it. It'll be 2 years this Wednesday that the county did their state of emergency. It'll be 2 years on Thursday that we moved the EOC to Randolph County Emergency Services. So it's been 2 years. Who would have thought we would still be talking about COVID-19 2 years ago?
It was 2 years ago today when the governor shut schools down.
Is it 2 years? Mm-hmm. Yeah. Don't ask me what I did last week, but I can tell you all those dates from 2 years ago. Anyway, since COVID started in March of 2020, there have been 35,334 cases in Randolph County. There have been 403 deaths associated with COVID in the county. And as of today, we're at 5.5% positivity. At this time, it's good to see that our outbreaks are starting to come down. We've got 4 outbreaks in congregate living. 3 of those are in long-term care. 1 of those is in the detention center. So we're making progress, y'all. And just as an FYI, the eligible population that has gotten vaccine, first dose, this is for Randolph County, is at 49%. Fully vaccinated is 46%. And so that's kind of where we are. We're not seeing a whole lot of people coming in for vaccine. I don't think we gave any first doses last week. You know, we started offering it indoors in January, Monday through Friday, and we're just giving a handful now. So, also COVID related, I'm sure y'all remember seeing or hearing, but mid to late January, the state sent N95 masks to all county health departments and DSS departments. We received 13,800. DSS got the same number that we did. You know, once we started off by getting those that were the highest risk, the mask, like EMS, law enforcement, fire departments, those kinds of folks that were interested. And once we had exhausted all of those avenues, we opened it up to the general population, and those things sold like hotcakes, even though we didn't sell them. But they left the shelves. And then DSS, we asked them if we could have some of theirs. They gave us some, so we helped them get rid of some of theirs. So in total, Randolph County Public Health, we were able to distribute nearly 19,000 of the N95s. I'm sure y'all are fully aware because none of us are masked today. But in mid-February, NCDHHS announced that if metrics continued to improve, that they were going to recommend effective March the 7th that schools and local governments or low-risk environments consider making masks optional. They encouraged folks like healthcare settings, long-term care settings, homeless shelters, detention centers for them to continue wearing masks because they are all together all the time. We asked the question, what metrics did you look at to decide to do that? And they explained the key metrics they were looking at to make that decision, where they were seeing fewer hospitalizations, which is a good thing. Fewer people going to the emergency department with COVID-like illness, and then, of course, more immunity in the community. So if people haven't had it, or more people have had it, there's people with vaccine or both. So thankfully, we're starting to see that immunity in the community. So hopefully, we're headed in the direction that we're going to just begin to live with the virus. But we will see. Just a quick update, we still communicate with StarMed. They did start scaling back just a little bit yesterday on their testing and vaccine. They are still offering testing at both RCC locations. Here in Asheboro, they're at RCC Monday, Wednesday, Friday, 3 to 7. In Archdale, they're at RCC Tuesdays and Thursdays, the same as they've been, 10 to 2. They are offering vaccine at RCC Archdale Thursdays from 10 to 2. And then they've scaled back on testing at the First United Methodist Church. It was Monday through Saturday. Now it's Monday, Tuesday, Thursday, Saturday, 12 to 6. And then they're doing vaccine at the church on Fridays from 12 to 6. So they've scaled back a little bit, but they're still here. Haven't heard anything about this in a little while, but we do anticipate vaccine for children ages 6 months to 4 years to soon be on the scene, maybe April-ish. So we'll keep y'all apprised of that. Any questions about COVID before I shift to other CD-related topics? Okay. All right. So as you may recall from the January meeting, our folks were working with 2 active TB cases. They're still working with those TB cases. Good news is one of those cases was able to come out of isolation in mid-February. He was determined to no longer be contagious, so he is now able to return to work and normal activities, which is a good thing. And then if all goes well, we hope to wrap up their treatment by the end of July for both cases. So y'all can see it's a long process. Our folks put a lot of time and effort to serve these folks. And I'll just say one of the cases, the living situation was a rental situation. And if you can't work, you can't pay rent or electricity or phone bill, we can't afford to lose somebody that's getting TB treatment. So our folks had to work. They worked hard to help find folks to help cover the cost to keep this individual located where he was so that we wouldn't lose track of him. Syphilis cases continue to be on the rise here in Randolph County. It's a nationwide problem as well. We speculate that the increase may be partly due to riskier sexual behavior, and then due to the pandemic, people weren't really being seen in person. They were just reporting symptoms and getting treatment. Now, hopefully that's improving. Folks are getting to a doctor in person, getting diagnosed, and getting treatment. So hopefully we'll see an improvement. Time will tell. So that's it for CD. You all have heard me mention that our dental clinic was going to have a program assessment. We had that on February 24th and 25th. D4 Practice Solutions was the company that did that. Dr. Bill Donegan, he is a dentist in the Gastonia area for an FQHC. He came on site and looked at our program from top to bottom, along with his co-worker, Dory Bingham. They looked at every aspect of our program from start to finish, and they yielded so much helpful feedback. They stepped on our toes a little bit, but that's what those kinds of assessments do, with the goal of making us better. So we're going to sit down and talk about what we can do to make our program as good as it can be. So we had that on February 24th and 25th. And the very next week, Dr. Mustafa and I were going to sit down and talk about this program assessment. And she asked me if we could talk about that another time. She just wanted to come in and catch up with me. And I had a bad feeling about that conversation. Dr. Mustafa told me that she feels like she has a passion for working with children, which is what she primarily does at the health department. But she wants to specialize in pediatric dentistry, which means more education. So she's leaving us. That was her news. We don't begrudge her that much. She's really good, and we love her, but we do not begrudge anybody that wishes to further themselves, and she has the opportunity. She's leaving us to move to Philadelphia to go back to dental school to specialize in pediatric dentistry. So that being the case, and Jennifer made a good point, yes, it's a little disappointing that we have this program assessment, but with our next dentist, we'll have everything planned out and say, this is where we're going with this. So if y'all know of a dentist looking for a job, we are looking for one. Y'all have heard me mention a space needs assessment. I should have lumped this under COVID, but I didn't. But during COVID, we quickly learned that we didn't have enough space. You know, we ordered lots of supplies, PPE, things like that that need to be kept in climate-controlled storage. We actually had some situations where there were employees sharing offices, and we really tried to separate people during COVID. So we've maxed out, y'all, every bit of our space at the health department. So the county has received some ARPA money. So they've hired Smith Senate to come in and do a space needs assessment. And they've given us 3 different options. I don't think we'll get to do everything that they've laid out, but they've given us some ideas of some things that we think we can do. And if the commissioners are able to approve some of that money for us, we may be able to seek approval from some of that COVID funding that I mentioned earlier that we have to be able to help with achieving some of those goals that are outlined in the space needs assessment. So hopefully it will work out that way. You guys have to remember our building was 1979, 1980. Now, it's been chopped up a good bit since it was first built, but you know, we could use some help in the flow of things. During the dental clinic program assessment, they told us we needed an additional operatory. Right now we have a hygienist operatory and then 1 dentist operatory. The dentist said we need 2 operatories specific for the dentist for her to be able to go back and forth between patients while the hygienist is doing her work. So as part of the space needs assessment, we may be able to shift dental around a little bit and get the ideal situation so that we can be as productive and sustainable as we can be. The last thing that I have to talk about is, you know, this space has been great for us to use during COVID, because our conference room has been an office space for surge staff. Plus, we didn't have a whole lot of room to spread out in our conference room at the health department. But I know I've been talking to Marty off and on for a little while about eventually moving back the Board of Health meetings to the health department building. And I just wanted to put that out there tonight to see if you all are interested or want to move back that direction, maybe at the next meeting if COVID kind of stays where it's at or keeps improving, maybe shift back there. We still do have people in the conference room, but we're down to 2 in that, so it wouldn't take a whole lot to shift around. So just thought I would get your feedback on that.
I mean, the reason we came here was COVID, obviously, and we wanted the space, and especially if we had anybody to join us. I talked with Tara about this a couple times, and it's a lot of extra work on you guys to come off-site and you know, prepare and have a meeting. So I'm in favor of making things, you know, more simple for you guys. If the board's okay with moving back in May, then I would certainly be in favor of that as well. So any other thoughts from the board? You guys okay with that, or? Okay.
Good.
All right. So
Okay,
we'll
so
plan on
that's
doing
what
that in
we'll.
May, unless something just breaks loose again, and then we'll revisit.
Let's hope not.
Well, if there's something that, you know, that's coming up that you feel like you need a bigger space, then we've used, you know, RCC, we've got this area, so.
Yeah.
But I like being back at the health department.
Okay.
I think it's more appropriate for the work we do.
I agree. All right. Okay. That's all that I have. Does anybody have any questions or comments?
Anything else? All right, do I hear a motion to adjourn?
I move to adjourn.
I have a motion from Robert, here a second. Second from Alan. All in favor, say aye.
Aye.
Opposed? All right, we are adjourned. Thank you, Tara.
Thank